Right. Okay. Okay. Right. I can see Kavish, Rajakantan, Gajarohanan. Right. So please indicate something if something is not going well. Okay. Right. Right. Okay. So today's topic, children, fibroids, and it's quite a extensive field with a lot of things that are new and a lot of some things that have come out new. So let's try and sort of make you all understand what it means. Now, if you look at the term fibroids, it's actually a misnomer. The reason being, now fibroid, correct terminology is leiomyoma. Okay, fibroid in the sense means it seems to be having more fibrous tissue. So there is more fibrous tissue there. So that is why it's called fibromas. But actually, or fibroids, but actually the correct terminology is leiomyoma. If you look at it, the leiomyoma, or I'm going to call it fibroid because it is the term that we are most familiar with. It starts off from one cell, and it starts off from one myometrial cell, and that is why it's called a monoclonal tumor. So every cell that is inside the fibroid, that particular fibroid, is the same as the other one, right? So what happens is, so because of this, and the fibroids grow from one cell in the middle, and it expands. So what it does is, starts off with one cell, becomes 2, 4, 8, and starts off, then it becomes millions and millions of cells, and it starts to grow. And then it pushes the myometrium further and further, and it flattens the myometrium, and it grows. So what happens is, there is always a tissue plane between the myometrium and the fibroid. Okay, so therefore, in a fibroid, it's very essential for us to be able to achieve or reach that plane if we want to remove it surgically, right? As the myometrial cells get flattened, it becomes more whitish, nearer to the fibroid. And at the same time, it appears to be like the fibroid, okay? Although there is a correct plane there. So this is very important because when you go towards the myometrium, it is very much near the cavity or the endometrium. So when you are trying to enucleate the fibroid, and if you do not recognize the plane properly, because the myometrium near the endometrium or the cavity is also flattened and it looks whitish, we might inadvertently take the whole cavity with us when you are removing the fibroid. So it will completely take off sometimes our intention or ruin the intention of what we are doing, because especially if we are doing myomectomy for infertility, right? And with the fibroid, which is very much near the cavity, if we remove the cavity itself from the uterus, then of course she will never conceive. You all understand? So the understanding that there is a plane and achieving that surgical plane is of utmost importance, specifically when we are very much near the cavity of the uterus, right? So the message is, and it's just a practical implication which I told you about, the message is that a fibroid or a leiomyoma is monoclonal, starts off from one cell, okay? The chances of it being malignant or a leiomyosarcoma is extremely small, ranges from about 1 in 300, 400 to 1 in about 1 in 10,000, is sometimes 1 in 30,000. It is unknown whether fibroids, the actual fibroids, can really turn into sarcomas. So we do not really know, right? So in other words, the chances of a fibroid being malignant is extremely small. How does it convert? Practically, if you see a fibroid in a woman, we do not need to automatically remove it, thinking that it's going to be a malignancy at a later stage. You all understand? So we practically, if we diagnose it correctly and we diagnose it as a fibroid, then we do not really need to remove it, saying that it might convert itself into a leiomyosarcoma at some point in time. Got it? Right. Now, if a woman does come to you with a uterine mass, there are 3 major differential diagnoses that you should have in your mind. What are these? One is a fibroid or a leiomyoma. The second thing, is it an adenomyoma, which is completely different to a leiomyoma. The third thing is it a leiomyosarcoma? These are the 3 things that should go in any doctor's brain, right, if they see a uterine mass. And they are actually different to each other. Usually, a fibroid can be diagnosed very properly. Why? Because there is a clear demarcation between the myometrium and the fibroid. So therefore, there's an absolute clear demarcation, and therefore it is quite possible to diagnose fibroids even with an ultrasound scan, right, up to almost 100%. The sensitivity is between 95 and 100%, right? So therefore, what is different is, or difficult is, the diagnosis between an adenomyosarcoma and an adenomyoma, although they do have their characteristics which we can differentiate, especially in MRI, right? So today's lesson is that we are not going to talk about adenomyomas and we are not going to talk about leiomyosarcomas, okay? We are going to specifically concentrate on leiomyomas, which are benign monoclonal tumors of the myometrium. Got it? Right. The lifetime incidence of a leiomyoma for women are about 30%. Right? So 1 in 3 women will have it. After about 30, 35 years of age, there'll be quite a lot of fibroids sitting inside tummies of women. Okay? And even at young ages, yes. At very young ages, right? Less than 18, at say very small children, the chance of having fibroids is very, very small. So essentially, it is a fibroid, or fibroids are tumors of the reproductive age, right? What is the reason? Because it has been found that for some reason, a single myometrial cell is driven to divide. And it is thought that they do have a difference or an imbalance of estrogen and progesterone receptors, right? So estrogen and progesterones become predominant because it is after ovulation, or the ovaries start to produce after menarche. And therefore, that is why fibroids will continue to grow or will start up when the woman is going to have her periods. And then when during menopause or after menopause, what happens is the fibroids will shrink because there is no longer a lot of estrogen and progesterone in the body that is produced by the ovaries, right? So postmenopausal, whatever she had will shrink, right? Maybe calcify and go down. Initial stages also, just after menarche, the chance of fibroid or fibroid to grow is less. So starting from that, in the 40s, for some reason, the growth of fibroids accelerates. If there are fibroids, maybe she had it for some time, and then after in the 40s, they accelerate. So you can see a lot of women coming to you, right, with fibroids after 40 years of age. Because logically look at it like this. Say she starts a menarche at about 12, 13 years of age, right? And then she's producing estrogen and progesterone. And then slowly, if one cell gets stimulated at some point, needs to divide into millions and billions of cells, it takes time. So therefore, everything that starts to develop, right, will probably develop along the 20s and the 30s and make themselves known in the 40s, right? So that is the reason that towards say 35, 38, 40, 42, 45, like that, then we have a more number of women coming to us with fibroids. And then in menopause, slowly they will start to regress. Clear? Next fact. Now, what are the risk factors? Well, first of all, age, right? So as I told you, the reproductive age is a risk factor. It is found that in obese women, the chance of fibroids are more. Why? It's because in obese women or overweight women, the production of peripheral estrogens are higher in fat tissue. So therefore, it is thought that there may be more fibroids there. One of the most significant factors is ethnicity. In Black women, the chance of having fibroids is far higher than in whites or Asians, right? So therefore, if in African and Afro-Caribbeans, the chance of fibroids. So ethnicity plays a very important role, the genetics of ethnicity. And therefore, in Asians also, there is a tendency, but each country, each race, each ethnicity will have their own sort of pattern of fibroid growth. Okay. So other things like nulliparity increases the chances of having more fibroids. Family history increases the chance of having more fibroids. So these are some of the risk factors which you might consider. But however, the risk factors itself are not extremely important because up to now, prevention of having fibroids is not actual option. Of course, if you look at try to lose weight or try not to be obese, try to have more children because nulliparity is a risk factor, right? So you can't change your genetics, you're born with it, right? So therefore, sometimes these may not be or cannot be modified. Okay, right. So that is the general overview of what we have to understand about fibroids. Now, practically, so we have spoken about what fibroids are, how they are, what they are exactly, whether they are, because they are monoclonal, starting off from one cell, right? And the third fact which I told you about, that might be dependent on ethnicity, on the genetics, right? And 1 in 3 women has a lifetime risk of, or 30% risk of having fibroids, right? And then the next important thing that you have to understand is, what do fibroids do, or how do women present to us with fibroids, which is the most important question, and that is what you need to understand, all right? First, it's one of the major causes of menstrual disturbances, right? If you look at menorrhagia or chance of bleeding, remember there is a classification called palm coin. Are you all aware of it, children? If you look at bleeding, right, there is a classification, PALM, right, and COIEN, coin, right? Classification of menorrhagia. So one of the major causes there in the palm coin classification for menorrhagia is fibroids, right? So what is P? P is polyp, right? A is adenomyosis, cause for menorrhagia, right? L is leiomyoma. Okay, M is malignancy, right? Coin is something else. There is also coagulopathy, you know, iatrogenic, that is medication, all that. That of course is not. So just remember palm coin, just look at it. In the palm coin classification for bleeding, the PAL, L stands for leiomyoma. Okay, so that is what we are talking about. So one of the main problems a woman will come to you with is bleeding or heavy bleeding, right? And how do these give heavy bleeding, right? So let's look at, in the palm coin question, in leiomyoma, it is classified into S and O. O is others. Okay. S means submucosal. So in the leiomyomas, for menorrhagia, excessive bleeding, S, it's subdivided into S and O. So, right? And S is submucosal fibroids and O is other types of fibroids. Okay. Now, what are these types of fibroids that are submucosal? So let's look at the uterus itself. If there is a fibroid living inside the endometrial cavity, what happens? It's basically a small stalk and a rounded mass inside the cavity. The endometrium tends to grow over it. So what happens? The Vargapa layer or the surface area of the endometrial cavity automatically increases, and that will cause excessive bleeding. Okay. So there are three types of these fibroids or submucosal fibroids. One is almost entirely the fibroid or the fibroid polyp is living inside the cavity. The second type is most of the fibroid is jutting into the cavity while only a small amount is in the myometrium, right? Which is called type 1. Type 2 is sometimes most of the fibroid is living inside the, or 50% of the fibroid is living inside the cavity, while 50% is in the myometrium, right? So these are submucosal fibroids. Okay. Then all these types will cause increased bleeding. Then what are the other types of fibroids that you can? Why do the submucosal fibroids increase bleeding? Simply put, two things. One is the surface area of the endometrium increases, as you understand, right? If it is completely inside, it increases for the whole surface area of the fibroid. If it is jutting into the cavity also, that also increases the surface area. And the other type is, other reason is, it changes the blood supply. Because fibroids, although they don't have a specific blood supply going into the fibroid like that, they get their nutrition by diffusion. So almost all the blood vessels are surrounding the fibroid, around the fibroid, not growing into it. What is the reason? Because it's a mechanism, it's monoclonal. One cell divides here, so they sort of grow, but they push everything out. Now, why don't they grow blood vessels? Because it does not have the ability to produce neoangiogenesis or they do not secrete factors that causes growth of blood vessels into it. In difference to malignant tumors. In malignant tumors, what they do is they want to live, right? And they want to spread. And therefore, they produce all sorts of factors. One of them are neoangiogenesis, or they form or produce factors that causes new blood vessels to grow. The fibroids don't do that. And therefore, the larger they get, they will have a very large amount of blood supply surrounding it, but not growing into the fibroid. So when we start cutting into the fibroid with surgical, we meet a lot of blood vessels, right, on the surface, but not inside, right? So at the same time, because it changes the blood vessels in the periphery, right, although it does not produce new ones, so therefore the blood supply changes, and therefore it can cause more bleeding. So one of the main things, right, that causes menorrhagia or excessive bleeding is what? Submucosal fibroids. Okay. The second area is the O type or the other types, right? What are these? These are fibroids that are intramural, right? Which is intramural, but just living underneath the endometrial cavity. Then there are completely intramural ones. Okay. Then there are subserosal ones to the outside, right? And then there are pedunculated subserosal ones. So these can be classified differently. And there are fibroids that live in different places, broad ligament, cervical. So they can live in different places. And very, very rarely there are parasitic fibroids, right? What are these? They actually are pedunculated fibroids, which grew up peduncle, and then they went outside. They started to get their blood supply from the surrounding structures, maybe the omentum, maybe from somewhere else, right? And then the pedicle necrotizes. And so they grow completely elsewhere from away from the uterus. So they live differently. These are fibroids that have sort of gone abroad, not in the uterus, right? So these are the foreign fibroids, as we say, right? Or parasitic fibroids. So these are the types of fibroids. Parasitic fibroids do not give menorrhagia. Okay, they can give pain. So the first thing that the woman comes of, if there is a cause to be found with a change or anatomical change for menorrhagia, the commonest morphological or change that you can find, right, are fibroids. Of course, there are other reasons without a change in the uterus due to the change in the intrauterine environment, or due to the hormonal changes or the imbalance, right? You can have bleeding. But if there is a cause that can be found, one of the commonest is a fibroid. Got it, children? Right. So they will come to you with excessive bleeding, with anemia. The hemoglobin may be very much low, and therefore, then when you do an ultrasound scan, you will find a fibroid. Got it? The second thing, symptom that they might come to you with in a woman with fibroid is dysmenorrhea or a menstrual disturbance. I'm still talking about menstrual. Why is there dysmenorrhea? Number one is, that's very painful menstruation. Anything that is living inside the cavity, say there's a fibroid polyp living inside the cavity, the uterus during the periods wants to throw it out. So it's going to, right? It's going to try to throw it out. And contractions causes pain. And therefore the woman experiences severe dysmenorrhea. Okay? So the woman might come to you not with heavy bleeding, but with severe pain. And you do ultrasound scan, and suddenly you find a fibroid living inside the uterine cavity. So that they can present with dysmenorrhea as well. Okay. What is the other reason that can cause dysmenorrhea? During the menstrual period or bleeding, the blood supply might get disrupted, whatever amount is getting, to the fibroid. And therefore, because the fibroid is living on diffusion actually. The blood supply is around it, and the cells live with diffusion because to get their nutrition. And suddenly if the blood supply for some reason disrupted and she's bleeding and therefore then the fibroids will start to degenerate. And a degenerative fibroid can cause pain, right? So dysmenorrhea may be due to that, okay? So that is the second symptom that we need to be aware of, and that the fibroids can cause this, okay? Third one, what is the other thing that the women come to? Infertility. That is the third problem that the women will have. They might not be having infertility, menorrhagia. They may not be having dysmenorrhea, although they may be having both. Plus, they're saying, I have no children. And when you do a scan or when you do the investigations, you find a fibroid. Now, what are the ones that are going to cause infertility? Number one, anything living inside the cavity will act like a intrauterine contraceptive device. Okay, so therefore, if you have a fibroid living inside the cavity, it is as if you have a natural contraceptive device inside. Okay, so therefore, that is what is causing infertility. Anything jutting onto the cavity with the distortion that can cause problems with implantation, right? And therefore, that also can cause infertility. Plus, it will disturb the normal endometrial pattern, and it will have problems with implantation as well as retaining the fetus. So miscarriages are higher with submucosal fibroids. Okay. Anything that is very much near the cavity, that is very much near the endometrial myometrial junction, will also disturb the endometrial and will cause problems with implantation. Of course, if it does implant, then the chance of miscarriage will become higher, right? There, because it is disturbing the implantation process, right? And therefore, it can also cause miscarriage. But one of the main reasons they come, if it is very much near the cavity or if it's a very large intramural, right, it will disturb the implantation and the uterine hemodynamics of natural physiological mechanisms of uterine activity that helps in implantation. So that also can cause it. So the ones that are, or if there is a large fibroid which is pressing against, say if it is in the fundus and pressing against both tubal origins, that also can cause infertility. If it is pressing against one and distorting the tubal origins, that can cause infertility. One of the main reasons, one of the other fibroids that can cause infertility is, remember, the ovary produces an egg. There's ovulation. Okay? It comes onto the surface and chemical signals go out. The fimbrial end is like a frond. Okay? And that needs to pick up these chemical signals, and by chemotaxis, the fallopian tube moves over the site of ovulation. And then ovulation occurs directly from the ovary into the fimbrial end, into the tube. So there is a selective pickup mediated by chemotaxis, mediated by the chemicals produced at ovulation. Okay? If there's a fibroid that comes in between and stretches the tube and the ovary apart, so what happens is there's a physical distance between these two. These mechanisms do not take place. So broad ligament fibroids, right, or anything that distorts the physical proximity of the fallopian tube with the ovary will change fertilization dynamics and will cause infertility. You all understand, children, right? So therefore, we need to understand that fibroids can cause this problem. So there may be broad ligament fibroids who are doing this, right? So it can cause infertility. So that is the third. First is menstrual disturbances, which are two, menorrhagia and dysmenorrhea, right? The third thing which we spoke about is infertility. Okay. The fourth way in which women will come to you, right, is pelvic pain or just pain. And what are the ones that causes pain? Yes, it can cause dysmenorrhea if it is living inside the cavity. But if it is very large, or for some reason, the blood supply is cut off and it becomes degenerative or it degenerates, a degenerating fibroid can cause pain. Because sometimes there's evacuation, there's a liquid collection inside the fibroid, and degeneration due to the blood supply has been cut off because it does not have a blood vessels growing into it. So therefore, it has to depend on whatever is in the periphery. The larger it gets, the more ischemic the fibroid gets and more pain it will cause. So fibroids can cause pain. It can cause constant pain all the time. And then it can also cause, the pain will increase with the periods, decrease with the periods. So it can change, but it will cause pelvic pain. The other pain syndrome, so it can cause pain syndromes, not just pelvic pain or painful. The other pain syndrome which it can cause is dyspareunia. So when the penis hits against a degenerating fibroid or a tender sort of fibroid, it can cause pain. And sometimes it can cause positional dyspareunia, right? In, say, especially in posterior wall fibroids, will leave it to your imagination as to how pain occurs in that, right? In the positions, right? It can cause specific pain during intercourse. I remember a patient who was overseas at that time. They've been having sexual intercourse for 1 year and they never had pain, and suddenly they changed on to a newly discovered position, and suddenly it started to be the intercourse starts to be hugely painful. It was so painful since they were abroad and they did not want to seek medical attention. They came here. I still remember how they described it to me as to in what position the pain occurs. And the ultrasound scan found a large 8 centimeter posterior wall fibroid. Okay, so the other things I will leave to imagination, but remember it is also called postural dyspareunia. So dyspareunia is one reason that the patients may present to you with fibroids, right? The next, then there are in some women cosmesis. What is cosmesis? The appearance will cause her to come and see you. The fibroids become so large that they appear or look pregnant. Okay, so therefore they don't feel it because the abdominal cavity has a huge amount of potential space for anything to grow, right? For the uterus to enlarge with the baby, it has enough room. For an ovarian tumor to grow, it has enough space. For a fibroid to grow without causing symptoms, it has enough space, right? So therefore, sometimes they don't really feel it, right? Until the people looking from outside says, "You look, your tummy is big," and sometimes they look very pregnant when they come to you. Okay, so for cosmetic reasons, they will come and say, "Look, my tummy is seemingly big." So therefore, that might be one reason they might come to you. The next thing, next type of presentation is pressure symptoms due to very large fibroids. Okay. If there's an anterior wall fibroid, remember in the pelvis, there are 3 organs that are there. Mainly, there is the bladder, there is the uterus, right? And there is the rectum in women. Okay, so 3 organs. If there's an anterior wall fibroid, right? What does it press against? It presses against the bladder. And when it presses against the bladder, the volume of the bladder becomes small, and they will have frequency because the bladder fills very quickly. The volume is small, and therefore she will get an feeling that the bladder is filled, and then she will have frequency. Okay, and sometimes, very, very rarely, a fibroid can press against the neck of the bladder and cause urine retention. So sometimes they might come to you with pressure symptoms and urinary retentions. where you might need to catheterize, and you find that there's a large anterior wall fibroid. Okay. The next thing is, if there is a posterior wall fibroid, it pushes or pushes against the rectum. And what does that cause? It causes constipation, right? So sometimes women will come to you with changed bowel habits, and mostly it is constipation. Sometimes they might find it difficult to initiate defecation, right? So because the rectum is getting crushed, because there's a large posterior wall fibroid. Okay. The other thing is, it can grow onto the sides very rarely, onto both sides or one side. And what is it? It presses against the lateral pelvic wall, and that presses the ureters, and rarely it can cause hydroureter, which means the ureter swells up, and then it can cause hydronephrosis on one or either side. Very rarely on both sides, sometimes on one side. So what does that give you? The woman will come and tell you, I have a severe backache. That is due to hydroureter and hydronephrosis, right? So that is one way in. And then there are fibroids that climb up into the tummy. And what does that give you? If it presses against the stomach, it will give dyspeptic symptoms, right? Might cause a feeling of bloatedness, right? If it presses against the bowel, it can give subacute bowel problems, right? If it presses against the diaphragm, if it is so large, it can cause shortness of breath, right? So these are the pressure symptoms that you need to be aware of. Of course, they need to be rather big, right? And quite big for to have these pressure symptoms, right? Next is the feeling of discomfort or non-specific problems that can be caused by fibroids. The women will have feeling of discomfort, feeling of lethargy, and very rarely fibroids can cause an increased production of erythropoietin. Sometimes it can cause an increased amount of blood cells, but these are very rare conditions which are not our classical fibroids, which we can speak about, right? So these are the times or when we this is the way the women present to us with fibroids. Okay. Now, what is very important is a large majority of patients will come to us, okay, because the fibroid is an incidental finding. Because now scans are done for almost every patient who meets a physician or any other doctor, right? An ultrasound scan of the abdomen, right? And as I told you, remember 30% of the women or even more, depending on the ethnicity, will have fibroids which is living there peacefully, okay? And then a scan is done and a fibroid is seen, right? And then say, okay, a fibroid or a tumor in the uterus. The women get extremely distressed, saying because there's a gadea, there's a tumor, okay? And then they will come and meet you. What is important is to make sure that you understand the chances of it being a malignancy is extremely small. And therefore, just because you see a fibroid does not mean that you need to remove it. And it is removed only based on one fact, whether this fibroid is symptomatic or not symptomatic, okay? And the symptoms I just told you, right? If there are symptoms, any of these symptoms which I told you, the fibroid needs treatment, okay? So if she's completely asymptomatic and there is nothing in all the things which I told you, that does not require treatment. Remember, there are 5 kinds of treatment which I taught you all, children. Remember? I hope you all remember. 1 is no treatment. You don't need to treat. 2 is medical treatment. 3 is surgical treatment. 4 is combined treatment, medical, surgical. 5 is alternative treatment, right? Which includes yoga, with different kinds of therapy, right? Exercises, massage, whatever. That's the alternative treatments. Okay, right? So if you look at this, so remember, if the woman is asymptomatic. Now, this asymptomatic also includes or does not include women who have psychological problems of having a tumor. Okay, then she becomes symptomatic psychologically. So there are women who, although there are no other symptoms, she is alarmed by the fact that she has a fibroid in her uterus. However much you try to convince her, look, this is, you are asymptomatic, this does not need treatment. No, doctor, there's a Gedia here. I don't want a Gedia. I want this removed, right? And I cannot live with it. I always live in constant fear that this Gedia is going to become a cancer. So therefore, I have finished completed my family. I really want this removed. And therefore, yes, so that is maybe one indication where you might need to intervene, because her psychological well-being is affected by the fact that she has it, right? But otherwise, mainly, most of the women, if it is asymptomatic and you give a clear example or a clear explanation, they will be all right with it. One of the main things when you give a clear explanation and discuss no treatment, okay, is that you need to give a follow-up plan. Look, come back in 6 months. This is not going to become malignant, right? Come back in 6 months or 1 year. We check whether it is growing. If it is growing, let us consider whether it needs to be removed. Do you understand? So that is one way which you need to reassure them and tell them that we will follow you up, right? And we will rescan you and check whether there is a growth. In that case, we will consider removal, right? So now do you all understand how women will come to you with symptoms, and there will be a portion of women who will come to you with incidental finding of a fibroid. Okay, so those are the two main categories, right, that you will find. Okay, so I will just ask for, let's see whether you have any questions, so I can move on to the other bit, which is the diagnosis of fibroids. Any questions, children? Ask away quickly, then if not, we will move. Yes, anything? Doesn't matter, just ask. If you have a question that's, came into your mind. I have Sapumal holding a mic. His picture is holding a mic. Sapumal, you can always ask me a question. You seem prepared for questions. Young gentleman there, smart looking man. Yes, no questions? Right, okay. Then shall I move on, children? Yeah? Am I clear so far?
Yes, sir, all good.
Okay, good. Right. I have 2 messages. Okay, there's a question. If fallopian tube cuffs ovary and take home in, why Mittelsmers? Okay. Yeah, right. Mittelsmers is a German word actually, and it means pain during ovulation, right? So pain is not dependent on the fallopian tube moving or not. Pain is dependent on the disruption of the ovarian surface. Okay, that is number 1. And the fallopian tube does not completely seal it, right? So therefore, there may be a bit of leakage, which can cause a bit of leakage or fluid falling into the surrounding peritoneum, and therefore that can cause a bit of pain, right? But ovulatory pain is not dependent on the leakage into the peritoneal cavity. So it's mainly dependent on the disruption of the ovarian surface in some women. So that is what causes mid-cycle pain. Okay. Can you differentiate leiosarcoma by ultrasound? Yes. Not exactly. MRI is a more appropriate method, but then in diagnosis, I will speak about it. Is premature menopause a known complication of uterine fibroid? No. When you say known complication, it's a very broad terminology, right? So if the fibroid is, pushing against the ovary, disrupting its blood supply, right? Growing inside the broad ligament and stretching the blood supply and having some problem there, very, very rarely it can happen, but it doesn't really happen on both sides. So therefore, the chances of it, causing premature menopause is extremely small. Can fibroids cause complications like severe anemia? And yes, severe anemia, yes. I told you because if she bleeds, she can cause anemia. Polycythemia, yes, because if some fibroids very rarely produce, very rarely produces erythropoiesis and therefore can cause polycythemia. Those are very, very. What is red degeneration? Red degeneration is when venous stasis occurs and blood is left inside whatever tumor oil. So usually that happens in different conditions. So usually we very, very rarely or do not almost see red degeneration. Can we differentiate fibroid from ovarian mass by clinical examination? Difficult. The more experienced you are, yes, but if you look at we will speak about that in, so see, a fibroid is normally attached to the uterus and therefore it moves with the uterus and the cervix moves with it, right? However, an ovarian tumor is also near the end, and if there are adhesions between the ovarian tumor and the uterus, even if you move it, though it will behave exactly like a fibroid attached to the uterus, because the ovarian tumor also may be attached to the uterus. So it is maybe difficult for us to. However, when you feel the surface, sometimes you can differentiate a fibroid due to its sort of uneven but smooth sort of surface, right? Are you going to discuss medical management options in detail later? Yes. So we are going to talk about non-surgical and surgical management, right? Okay. So let's talk about diagnosis. Okay. Now, the mainstay. Now, first of all, remember, we always need to go in a very logical manner. First, for the diagnosis, so she will come to you. Remember, this multitude of, I have spoken to you the multitudes of symptoms and how they are generated. Okay, and I have told you the mechanism of how they are generated. Got it? So when they come to you, okay, the next portion is, remember, always what? Abdominal inspection. What will you see? You will see sometimes an uneven surface, a protruding surface. You can see. Sometimes if it is very large, you can basically see the abdomen, which is swollen up. Okay. Next is palpation. In superficial palpation, if it is quite large, you can feel it. In deep palpation also, you can feel it. So when there's a mass, there's always 9 or 10 things which you need to talk about in a mass. Okay, you know what it means. First of all, if you look at the video on gynecological abdominal examination, I would have spoken to you about the characteristics of a mass, which you need to go back and check. Just to sort of again discuss, not discuss, just just list them out is what we need to first say in what areas this mass is occupying. You know, the 9 areas of the abdomen, right? You know, talk about the size in comparison to a gravid uterus, that is 20-week size, 30-week size of a gravid uterus, 14-week size of a gravid uterus. So you need to compare this mass with the gravid uterus. Okay. Then you talk whether the surface is smooth or not. So usually an ovarian cyst will have a smooth surface. Here it will not be smooth, but maybe smooth, right? Then you need to talk about whether it's tender, because if there's degeneration, it will be tender. If there's no degeneration, it won't be tender. So you can say it is not tender or tender, right? Then you can talk about mobility, whether there is transverse mobility or mobility which is towards the cephalad or the pelvic side, okay, right? So you can talk about its mobility, right? And then you can always talk about what the surface, whether it is smooth or whether it is uneven, right? And then percussion, there should be a dull sound only if there's a lot of liquid there, which is due to degeneration, but it's hardly ever anything other than dull, right? So, and there will usually not be any free fluid because fibroids do not secrete fluids, right? So it's malignancies that you might have, ascites and free fluid, okay? So those are the things that you will need to say. So abdominal exam. Next is a vaginal inspection and a vaginal examination. So usually the mass, when you push the mass, the cervix will also move with it because it's a uterine mass. Ovarian mass, if it is attached tightly to the uterus, then of course it will do the same thing. So it might be difficult to differentiate, but in consistency, the fibroid is quite sort of hard. So you might be able to have a sort of okay idea clinically as to what it is, okay? The next is, so those are the clinical findings which you have to learn. Remember this getting below the mass, getting over the mass, that is not a very relevant clinical thing which you have to understand. Maybe at undergraduate level, yes, maybe. Now remember, if it is a pelvic mass, it is taught that when you palpate, usually you cannot get below the mass in a pelvic mass based on the fact that it is growing out of the pelvis into the abdomen. But on the other hand, remember, there may be abdominal masses growing into the pelvis. And therefore, we will also not be able to get under the mass just above the pelvic bridge. You all understand? So it might not be a very clear, but most of the time, yes, in the fibroids which are rising from the uterus itself, you will not be able to get under the mass. But you need to be very careful because there may be abdominal masses growing into the pelvis and you will think that it is a pelvic mass, but it might be a tumor that is growing inside the abdomen as well. Okay, right. So those are the clinical findings. The next step in your findings, right, is what? The investigations that we are going to do. Okay, remember, generally, how do these investigations fall? I have taught you what? 2 large categories. What is the first category? Things that we do to diagnose what it is or the nature of the problem. The second large category is things that we do to find out whether this woman requires treatment or whether this woman requires an intervention. And if so, what, how do we optimize her for any form of treatment or surgical intervention? Is that of fitness for surgery? Is that clear? So let's look at the investigations that we require to diagnose this. And remember, that falls into 4 or 5 categories. What we find in urine, what we find in blood, what we find in x-rays, and what we find in special investigations. Okay? Urine, will the fibroids give anything? Usually nothing much. Okay? She might be prone, if it is an anterior wall fibroid pressing against the bladder, causing frequent urination with displacement on the urethra, she might have frequent retentions, and retentions also can give urinary tract infection. So urine tract infection is a possibility, but it's a you know, you go round and say that, so it is not a direct thing which you are going to find. Blood, what are you going to find? Because of, if she's having menorrhagia, the hemoglobin will come down, right? So full blood count, you will have polycythemia, hemo concentration, you know, high HB, all those are very rare complications which you do not need to remember or think about, but mostly it will be low or anemia, which is reflected in the. So if you do a blood picture, you will have a iron deficiency anemia due to the loss of blood. Okay. Next, in X-rays, yes, you can see the outline of fibroid, and especially if there's calcification, you should be able to see that. But we hardly ever rely on X-rays to find out what the fibroid. Special investigations, these are what? There are mainly two, right? Number one is ultrasound scan. Number two is MRI. Okay. Now, ultrasound scan gives almost the same sensitivity as the MRI. And if you are a good ultrasonographer, right, as obstetricians and gynecologists, we normally do our own ultrasound, right? You should be able to normally see a very good picture or diagnose a fibroid for what it is, right? Because there are certain characteristics which is different from a leiomyosarcoma and a adenomyoma. What are these? In a leiomyoma, the border between the myometrium and the tumor is very well defined. In adenomyoma, because it is endometriosis or endometrial tissue living inside the myometrium, so there are no borders, right? They are all diffusely enlarged and changed. While in leiomyosarcoma, there is definitely no border, and it is diffuse and large with degenerative changes and everything. So there is a large difference between these. So it might be difficult to differentiate a adenomyoma and a leiomyosarcoma, but it is usually very easy or possible for us to differentiate these two from a fibroid. Right? So if there are any suspicions of adenomyoma or a leiomyosarcoma, you need to step into the next phase, which is what? MRI. Okay, because MRI has a good sensitivity of differentiating a fibroid from a adenomyoma or a leiomyosarcoma. Is that clear? Right? So you do not just rely entirely on ultrasound scan. But however, if the ultrasound features of a fibroid with uniformity, well-defined edges, right? And you can see the hole around it, right? Sometimes there may be degenerations, calcifications with blood supply around it properly without blood vessels, or the Dopplers will not show any blood vessels going into it. While an adenomyoma, you will have blood vessels within it. Adenomyosarcoma also, you will have neoangiogenesis. However, in a fibroid, there will be only blood vessels around it. And therefore, using Doppler and ultrasound scan, we are normally able, almost 100%, where the sensitivity, where we can differentiate a fibroid from the other two. Is that clear? If there's a doubt, then you go for MRI. Okay. The next most important thing when you diagnose that, right, is to try and map the fibroids. Because if you are going to operate on that patient, and if you are going to do it laparoscopically, it is extremely important for you to be able to find exactly what is where. Okay, come, give me a moment. Where do you want to go? Right, okay. So So where were we? Right. So it is extremely important for us to find out or draw what the size of the fibroids are and what the locations are. Because if you do not map the fibroids before you go into a laparoscopic myomectomy, then you will start to miss things and you will leave things there. Okay, so it's extremely. The best way to map is not by ultrasound scan, but the best way to map is by MRI, if you want to map it. However, if you are confident that you have got every single small fibroid mapped out with their dimensions, then of course you don't need to do MRI. If you are a good ultrasonographer for your own fibroids, then you should be able to match it without a requirement of a MRI, right? Next, then that is the diagnosis. So we go for MRI only when we have a suspicion that this might be a leiomyosarcoma or a adenomyoma, right? But most of the adenomyomas we should be able to also diagnose. Leiomyosarcoma, on the other hand, will, other than just a foci in the uterus itself, it might already be having other foci elsewhere, in the liver, in the spleen, in the abdominal cavity, in the kidney, right? Or in the peritoneum, there may be other masses also. So therefore, it is of utmost importance, if we are going to operate on a patient for fibroids, it is of utmost importance that you should have done an ultrasound scan abdomen and an ultrasound scan KUB as a screening measure to make sure there are no surprises for you when you go inside. Okay, so that is for you all, for all the people who are going to become gynecologists, right, in the future, right? And that you can, if you are going to do a fibroid, please don't have your main foci or focus as the uterus while forgetting the rest of the abdomen, because you are going to, if you go in and finally you find a leiomyosarcoma with all sorts of, or you go in and remove it and come back, and then the histology will say leiomyosarcoma, then you go do an ultrasound scan, then you suddenly you find all masses everywhere, right, which you have missed, right? And then you will be sued, right, for missing that. So therefore, it is very important to have your AOs now, right? And then make sure that you don't miss something like that. Okay, right? So therefore, where are we? So that is the diagnosis, which is simple in a way, right? You know the dimensions, you can measure the dimensions, and it is important to measure the dimension across and the 3 dimensions, and then where it is exactly and what its relationship to the cavity, because that will tell us whether intervention is required or not. Because if the woman is having infertility and then you have a fibroid which is subserosal, right, you don't need to intervene, you can just leave it. Okay, remember, infertility, I did not tell you about, is caused mainly by what fibroids? In the cavity, pressing against the cavity, and very much near the cavity, while the others do not cause. So those may not require intervention. If the woman comes to you solely for infertility and you find these fibroids, you can just leave them alone. Got it? So that is the ultrasound diagnosis, and when we use MRI as a extra investigation for us to do, right? So that is all about investigations. Is that clear, children? Right? Any questions that you all want to ask? I will wait. You all can tap in your, if you want, you can. And so I will wait 30 seconds before going on to medical treatment. I will give you an overview of medical treatment, and then we will go on to surgical treatment and follow-up. Right? Any questions? Any place for biopsies? No. If you are suspicious that it's a leiomyosarcoma, maybe. But we normally ever do biopsies of a diagnosed fibroid. No? Right? Anything else? No? Right. Then shall we move on to question? What is the difference between leiomyoma and adenomyoma? Okay. Right. There's a huge difference. I did not talk about adenomyosis, which we will at a later stage. But if you just want a small introduction, it's this. Now, the uterus has a myometrium and an endometrium, right? With age and with interventions, say cesarean section or evacuation of retained products or dilatation and curettage or disturbances, the endometrium will migrate into the myometrium, right? And the cells and the stroma of the endometrium will start to live inside the myometrium. So since it's endometrium, they will follow the same cycle as the endometrium line in the cavity. So they will become proliferative, they will become secretory, and then they will bleed. So, but they bleed inside the muscle of the womb, and that causes severe pain and ischemia. And also because it bleeds and causes ischemic changes inside the muscle, that causes what? Hypertrophy and hypoplasia of the uterine muscle. So the muscle increases. So you have a changed myometrium, which is, it gives three main problems. One is it gives menorrhagia. Second thing is it gives extreme pain during periods, which is dysmenorrhea, because it bleeds inside the muscle during the period. Third thing, it gives dyspareunia. When the penis hits against the adenomyotic uterus, it causes pain. So these are the three features, main features of adenomyosis, right? So that is the difference. You all understand? It's a variety of endometriosis that is inside the uterus actually, right? Because by definition, endometriosis is anything outside the uterus, right? So adenomyosis is a different kind. Right, suddenly there's a huge number of questions. Right. So the next thing is we are going to go on to special investigations, right? Because we have to talk about subserosal fibroids, which I will speak to you. What is the difference between leiomyoma and another type of? What to expect in vaginal examination fibroid? Can you explain again? Well, when you do a vaginal examination, you are basically going to find a large uterus, right? So you might not find a separate mass because it is arising from the uterus itself. So therefore, the uterus will be enlarged. So you have to explain it's 10 cm, 14, it's equivalent to a 14 cm weak gravid uterus also. And the next thing is when you push the fibroid or the abdominal mass with your fingers, or if you can push it, the cervix will move with it because it is attached to the uterus, right? And then, so that is something that you will, so there is, the cervix will also go with the mass. Although if it is a ovarian mass attached to the uterus, that also anyway will move as well. So, sir, Aki is asking if you should always send a fibroid for histopathology or not. Young man, please tell your Aki that it is essential, right? So anything which you remove from a patient has essentially and absolutely necessary to go for histology. That is a must. Okay. Is there a place for hysteroscopy? Yes, I am getting to that. So I will discuss that now. You mentioned about getting sued for missing leiomyosarcoma if missed the metastasis. Wouldn't it be beneficial to remove the uterus anyways? Is this because we consider another approach for the management if found prior to surgery? Right. Now, leiomyosarcoma, if you find it, thing is this. If there are complete indications, right, and you have done a complete thorough workup of the patient, right, and you have done everything possible to diagnose or make sure that it is not something else, and still if it is a leiomyosarcoma, the chance of you getting sued is less, right? However, if you go in, right, and find something else that you have not told the patient about, and to conduct the surgery and then find that it's a leiomyosarcoma, we are basically converting stage 1 into stage 4 if you do something there. So therefore, remember, you go in for what you have consented for. And if there's anything more, you need to come out and discuss with the patient at a later stage. The other thing that is very, very important is that morcellation should not be performed. Electrosurgical morcellation is not being performed now, which we'll talk about later in surgical management, because you can spread a leiomyosarcoma around the abdominal cavity if you do electrosurgical morcellation. But that is a question for later. Right. Okay. Somebody has just called himself stupid, but I'm not going to mention who. Okay. Right. So, children, what is the next step? We need to talk about diagnosis. The next important diagnosis or instrumental diagnosis is hysteroscopy. Right? What is hysteroscopy? You put in a telescope inside the uterus, and we do this to evaluate any fibroid which is inside the uterus and any fibroid which is jutting, or submucosal fibroid which is jutting into the cavity, right? Remember I said there can be 0, 1 and 2 types of fibroids, because in a fibroid that is completely inside the cavity with a small stalk, the intervention is trans-cervical through the cervix, resection of the fibroid. That is a special instrument which we can, through the cervix, cut away the fibroid. If the fibroid is submucosal and most of it is in the cavity and a small amount in the myometrium, right? And by hysteroscopy, where we have to diagnose, we see video. What do? We look at the angles in which the fibroid connects with the uterine cavity. If the angle is less than 90, right? See, if this is the uterus and the angle is less than 90, this cone, right? It means most of the fibroid is inside the cavity. So that is resectable by hysteroscope, right? If the fibroid is jutting only a small amount like this into there, and the angle which it falls is more than 90 degrees, that means most of the fibroid is inside the myometrium, while only a small amount is outside. Those are not resectable by a resectoscope or transcervical resection of fibroid, because you can't go on cutting, you will fall into the abdominal cavity through the cervix. You all understand? So therefore, we do a diagnostic hysteroscopy to find out what is the ideal mode of treatment for this particular fibroid. The other thing which we can use is sonohysterogram, right? That is, you can do it by you inject a small amount of normal saline into the cavity and then you perform an ultrasound scan. And that will show us how the mass is properly, because the cavity gets distended and you can easily or have a good picture as to whether that is sono-ultrasonography, right? Hysterosono-ultrasonography, where you inject water right? And then since the cavity gets distended, but you can see the fibroids that are jutting into the cavity and what they are. The third one, which we find these fibroids or masses, is HSG, where usually it is done to check whether the tubes are patent, and in the phase you can see fill-in defects, and there you can diagnose masses which are inside the cavity. And anyway, for those we will have to do a proper hysteroscopy to diagnose what type and what it is, because it can be a endometrial polyp as well. Okay, so this is the diagnosis which is complete. So therefore, what are the tools we have? We have ultrasound. It's usually transvaginal, right? For those who are not sexually active, we are able to do transrectal scans, right? It gives almost the same, because there are rectal probes, so same sort of information. Abdominal ultrasound we need to do initially, and then we go on to either transrectal or transvaginal. Then we can do MRI, and that will give us better fibroid mapping, right? And also it will show us very small things, and also it can differentiate better a leiomyosarcoma and an adenomyoma, right? We can do more differentiation, but the ultrasound, the radiologist needs to be good at it. Then the other diagnostic tool is what? You can instill a bit of water there, normal into the cavity, and do a hysterosonogram, right? Where you do ultrasound after installation of normal serum. Or an HSG will sometimes give you a fill-in defect, but we need to investigate that further. And the last thing is the diagnostic hysteroscopy, where you put in a hysteroscope and visualize the cavity, right? So those are the diagnostic methods which we use to diagnose fibroids and where they are and their dimensions, right? So that should complete our diagnosis. So please explain sonohysterogram. I just did. I think the question was before my explanation, but it basically means you put a small tube into the cervix, inject some saline, right? It distends the cavity, and then you do an ultrasound at the same time, and then you can see the cavity nicely. Just Google it, you will see nice pictures of fibroids inside the cavity. Okay, so that, where are we now? So we have finished diagnosis. Okay, next is what? Is treatment. So treatment, as you remember, it's do nothing. Then it is medical treatment. Then it is surgical, combined, and alternatives. Alternatives are out, right? We don't treat. So remember, treatment, I don't know. Maybe there are methods. I have no idea. I'm yet to see a successful alternative method or in alternative medicine for treatment of fibroids. Maybe they exist. I don't know, right? I have not yet seen them, right? So I do not know how, whether it is possible or not, but I do not know, right? So let's go on to medical treatment. Now, we have to target the problem. Okay, so remember I told you there are a spectrum of problems that the women come to us with, and then we need to treat those. Okay, so if you look at if it is menorrhagia, okay, she is bleeding excessive. What are the medical treatment we can give? Yes, we can try mefenamic acid, 500 milligrams 3 times daily at the start of the period, maximum of 7 days that you can try. The second thing is we can try tranexamic acid, which is which can be used to reduce the amount of bleeding, which can be started 1 day or on the day of bleeding and then continue for a maximum of 7 days. We can combine those together for fibroids causing menorrhagia, right? And that might give us efficacy, right? But may not be much, but it can be controlled that way. Next is if they do not want fertility, You can try combined oral contraceptive pills. That will reduce the amount of proliferation, as I have explained to you how it works. So combined oral contraceptive pills for women who do not have fertility issues, but menorrhagia is the only problem and you have found a fibroid there, then you can try combined oral contraceptive pills. Remember, if they have fertility issues, right, then you can't give oral contraceptive pills. The next thing is a levonorgestrel releasing intrauterine system. You can put this in or a Mirena, right? And that releases levonorgestrel into the cavity. That will cause thinning of the endometrium, and that can cause reduction in the bleeding, but it can cause a small amount of reduction in the fibroids themselves, but we do not use levonorgestrel intrauterine system to treat fibroids. We are putting in the levonorgestrel intrauterine system to treat menorrhagia caused by fibroids. Remember that, children. Okay, so that is a possibility. Yes, we can use dipomedroxyprogesterone acetate as 3 monthly injections. However, they have their side effects. This will cause amenorrhea, and usually in most of the women, and we have to repeat it 3 monthly. However, one of the side effects is the women might feel a bit of bloatedness. They might have a weight gain of 3 to 4 kilograms per month, and we cannot continue it for a long time, maybe not more than 4 or 5 years, because there are other problems that might come in. And with time, as you continue to use it, you will have breakthrough bleeding, which might be difficult to control. So therefore, that is also an option, but may not be a very good option. Then, so those are the medical, commonly used medical problems. Now, one of the major things which you have to remember is that ulipristal acetate, or ulipristal acetate, which is a progesterone receptor modulator, okay, came into the limelight, right, as one of the most effective treatments for fibroids, and especially for bleeding caused by fibroids. What does it do? It causes apoptosis or cell death of the fibroid, and also it reduces its sensitivity for the receptor sensitivity on the fibroids, and that causes the fibroids also to shrink. And there were 3 studies done: Pearl 1, Pearl 2, Pearl 3, all of which showed amazing and good results, right? You compare ulipristal acetate to GnRH, you compare that to tranexamic and COCP and other available and for myomectomies, and this gave a lot of good results with good patient satisfaction. Unfortunately, something bad happened. Very, very rarely, women started to develop fulminant hepatic failure on ulipristal acetate when used for menorrhagia that is caused by fibroids. What does that mean? That required liver transplantation. Okay, and therefore, after a huge ha-ho and lot of studies came in, all the trials were successful. It was released into the market. People started getting it. They were very happy on it, right? Unfortunately, some of the patients reacted with fulminant hepatic failure, right? And hepatitis, right? Which led to and then the drug was withdrawn from the market as a treatment for menorrhagia caused by fibroids. So it is no longer available. Okay, so that is ulipristal acetate. Now, there are lots of other experimental drugs which is being used. Mifepristone is one of them. Causes shrinkage of fibroids, reduces bleeding, but still it is not licensed, right? And there are different types of raloxifene, tamoxifen, which are selective estrogen receptor modulators, which blocks these receptors, right? Also causes shrinkage and treatment of fibroids, but all these are not yet licensed and stage, but they are not been extremely successful, right? So therefore, for the moment, selective estrogen receptor model, which means what? Selectively, they do changes to the estrogen and progesterone receptors on the fibroid, right? These are raloxifene, tamoxifen, right? All these things, right? They are not yet licensed. Ulipristal acetate was licensed and withdrawn, right? And then mifepristone is being checked in trials, giving some results, but may not be some wonderful drug. So therefore, still it's not licensed. In the future, there may be technology where if a cell is grown, then the cell can be also degrown or can be made to reverse itself, right? So those treatments are something of the future where at some point we should be able to treat these before the fibroid starts to grow, and maybe detect them at very, very, very early stages where we can stop the proliferation of these fibroids. But that is yet to come, right, in the future. Okay. So that sort of gives us an overview of all the medication that we use for the moment for menorrhagia caused by fibroids. Okay. Next is what? Generic analogs. Now, generic analogs will completely knock off all the estrogen and progesterone in the body. Remember, fibroids are estrogen and progesterone dependent. So, mifepristone is a progesterone antagonist. That's why it causes the fibroids to shrink, right? Generic analogs can be used as temporary measures because you cannot use it for a long time, maximum 6 months with add-back therapy. Add-back therapy means to combat the reduction in the estrogen in the body, you give a bit of hormones so that the woman will not be feeling menopause, right? But generic analogs will reduce the size by about 40 to 50% of fibroids, will completely knock off the estrogen and progesterone. Therefore, there will be no bleeding at all for the woman, but it can be continued only for a maximum 6 months, right? And when you continue it further, the woman will get osteoporosis and thrombocytopenia. So therefore, we do not use it for a long time. So generic analogs is used in conjunction as a mixed or combined surgical medical treatment, where you might want to reduce the size of the fibroid for you to operate on. So sometimes when there's a very large fibroid, you can give generic and shrink it and then go for a laparoscopic myomectomy. Or you can shrink it and instead of doing an up and down cut, you can do a PF cut, Fanon style, to remove the fibroid. Or instead of, if you want to remove the uterus along with it, you without cutting it, you can shrink it and do a vaginal hysterectomy. So those are usually, generic analogs are usually used in conjunction as a combined treatment of medical and surgical treatment, right? However, it has its disadvantages, which I will tell you. When it shrinks, the myometrial fibroid junction becomes blurred. So sometimes it's very difficult to get the plane to properly do an enucleation of the fibroid. So those are the disadvantages of generic, plus you cannot continue them for a long time. Okay, so that covers almost all the medical therapy that is used for fibroids, and that is more than enough for you to understand the medical treatment. Right, I'll take some questions here. Are we going for this hysteroscopy, HSG or hysterosonogram if it is submucosal fibroid only? The best is hysteroscopy. HSG is usually an incidental finding of filling defect because you are trying to go to have a look at the inside the cavity and the tubal patency, right? So if there's a submucosal, it is important to a diagnostic hysteroscopy because you want to diagnose whether this can be done by resection through a resectoscope through the cervix, or whether we need to go from above and remove it if the fibroid is mostly in the myometrium. So therefore, hysteroscopy is important. Before any planning of a resection, a diagnostic hysteroscopy is a must. And in our unit in Kalu Boiler, we just do a outpatient diagnostic hysteroscopy to find out which type of submucosal fibroid is it, and then we plan the surgery to a later date. How COCP helps in medically managing fibroid? The mechanism. Fibroids are not medically managed by combined oral contraceptive pills. Menorrhagia caused by fibroids are managed by combined oral contraceptive pills. Okay, you need to be very clear about that. However, a small effect may be there. Why? Because when you give combined oral contraceptive pills, it is a very small dose, and that small dose will suppress the signals that is coming from the pituitary to the ovaries to produce ovarian hormones. So therefore, because the ovarian hormones are driving fibroid growth, the oral contraceptive pills, by cutting off the ovaries from working, will reduce its growth. So yes, pre-exist, it doesn't shrink it, but it will stop the acceleration of fibroid growth, but then not to an extent we might require to do so. If fibroids are under the influence of progesterone, won't the LNG-IUs given for HMB cause the fibroid to get bigger? It's levonorgestrel. What it does is, it is as a treatment modality for menorrhagia caused by fibroids, right? I keep on repeating it. So therefore, remember, it is not for fibroids. Okay, it is mainly as a treatment modality for men. So LNG-IUS in itself is not a treatment modality for fibroids. It is for menorrhagia, right? Since it's inside the cavity, it will thin out the endometrium and then therefore reduce bleeding. Okay, right. So then we go on to the next segment, which is what? Modalities of surgical management of fibroids, right? So basically, the surgeries, remember then, wait, did I complete everything? Right. So for menorrhagia, I talked about the medical treatment, right? Then for infertility, medical treatment of fibroids is of no use. Why? Because if the fibroids are causing infertility by jutting into the cavity, living inside the cavity or in the myometrium, then there's no point in giving medical treatment, right? So you have to remove it physically. So fibroids are causing infertility, it's surgery. Okay. The next one, I said, if there are pressure symptoms causing pressure symptoms, then definitely the management is surgical. There is no medical treatment. Of course, you can reduce the size by 30-40% by giving GnRH analogs, but that has to be followed by surgical treatment. If the fibroids are giving pain, right, then of course one of the options might be GnRH for some time, but then usually you need to remove it surgically, because most of the medical treatment is not going to work very well for fibroids that is giving pain. So usually the management is surgical. If the problem is cosmesis, where the tummy is jutting out and the woman cannot wear the dresses she wants and looks pregnant while she is not, right? So therefore, of course, the treatment will normally be surgical, unless you want to shrink it a bit with GnRH analogs first. No other thing will shrink the GnRH to an extent where, other than GnRH, to an extent where it becomes smaller, so it is not noticeable. But you cannot continue that, because you have to stop it at some point, then it will grow back in 5 to 6 months to its original size, right? Then if the problem is pressure symptoms, frequency, if it is bladder, constipation, then of course the treatment is entirely surgical, right? And therefore, so that is how you need to be able to look at it. If it is symptomatic, then of course, if the woman is highly worried that there's a mass and doctor, I need this out and I don't want this and this and that time she's depressed and she says, I do not want any masses anywhere in my body, then of course you have to remove it. There's no option, right? So that is how you need to understand about the treatment modalities. Right? The next thing is, what is very important is, now if the woman, now a fibroid can be single, it can be multiple at the time of presentation, right? And there may be a few. what is really important is you have to understand is that when you are looking at one fibroid, there may be thousands or millions more inside, which we do not see with the naked eye or not physically seen, right? It may be because each myometrial cell has the ability to divide and become a fibroid due to reasons that we are not, because they may be estrogen dependent, progesterone dependent. We do not know why it sets off, but however, there may be thousands of small fibroids which is not visible. So we remove 1, 2, 3, 4. Sometimes you remove 90, right? Sometimes you may add 4, 5, 6 large ones, right? So you remove it, still inside the myometrium, there'll be invisible fibroids that are growing. So in another 3, 4 years, if the woman is prone to grow fibroids, again you will have fibroids everywhere in the uterus, right? You all understand? So when you are considering the surgical options, you have to remember, you have to tailor make your management towards a woman. For example, if she has not completed a family, then of course there's only, she wants more fertility, one option. And if that requires, if you think that it is causing an infertility and it's symptomatic, you have to remove surgery. Okay. If the patient has completed a family, right, and she has multiple fibroids, then hysterectomy becomes a surgical option than a myomectomy, because you remove the fibroids, she has still completed a family, then again the fibroids will grow back in another 1 or 2 years, right? And then again, unless she insists that she wants a uterus, right, and that she feels incomplete without having a uterus, right, then of course the best option would be not a myomectomy but a hysterectomy in these cases. Do you all understand? So that is how you look at myomectomy or hysterectomy in women who have completed their families and do not wish to have any more babies. Okay, right. So then let's now, so what are the surgical modalities available? Myomectomy by laparotomy, which can be up and down if it's very large, or by Fanon style incision or transverse incision. Okay. Second, so that can be something, or a vaginal myomectomy, which is rarely performed. However, if the fibroid is growing into the rectovaginal septum, or can be seen, or can be felt, or if it's a cervical fibroid, or if it's a fibroid that is jutting out through the cervical os and filling the vagina, which you can see, right? Remember, children, I recently had a patient whose hemoglobin is very, very low, right? She has been to so many doctors, right? Nobody has done a speculum examination, unfortunately, or a vagina. So they have missed the fibroid which is living inside the vagina actually. So it has come out through the cervical os and it's very large, 5 by 5 centimeter fibroid polyp living inside the vagina, and that as she has been having menorrhagia, right? And her hemoglobin has dropped down to 4, 5, very, very low, right? So it's simply because a vaginal examination was not performed, or a complete or a speculum examination has not been performed, right? So those remember that when you are, if a woman comes to you with bleeding, please do us, make sure that you do essentially a speculum examination, and make sure that you do a vaginal examination if she is sexually active, right? Then, so you can have an abdominal hysterectomy, up and down or transverse. You can have a vaginal hysterectomy, vaginal myomectomy, which is possible. Then if we have chosen to remove the uterus along with the fibroids, then we can do an abdominal hysterectomy, either by up and down incision or front side, or you can do a vaginal hysterectomy if you are confident that you can deliver the fibroids through the vagina. Even very large fibroids can be delivered through the vagina when you do a vaginal hysterectomy by hand morcellation, and there are techniques to slowly take out the uterus piecemeal if you do that. Or the next step is you can perform a myomectomy laparoscopically, or you can perform a laparoscopically assisted vaginal hysterectomy, where you can deliver the uterus with the fibroids through the vagina, right? Or you can perform a laparoscopic hysterectomy, and then along with the fibroid, you can remove the uterus as well, right? So what is very important is, now you all understand the options. You can have abdominal approach, right, with up and down incision or transverse. You can have a vaginal approach, which is a vaginal hysterectomy or a laparoscopy. Then you can do a vaginal myomectomy. You can do a abdominal myomectomy or a hysterectomy, right? You can do a laparoscopic myomectomy, or you can do a laparoscopic hysterectomy with the fibroid. Okay, so those are all the options that we have for surgery. What is very important in this is that we should not be using, now what is the most important when you do myomectomy is specimen retrieval. How do we get the specimen out? And we are talking about what? We are talking about minimal access or laparoscopic surgery, right? Till 2014, right, in I can't remember the city now. Was it Bristol? I'm not really sure. A woman underwent a myomectomy, and the method chosen for the removal of the specimen was morcellation. What is morcellation? There's a gadget that crushes the fibroid and takes it out. It's about 1 centimeter in diameter, or there are 1.5 centimeter diameter morcellators. So it's called electrosurgical morcellation because there's a blade that is going around inside the morcellator, which is crushing the fibroid. What it does is it spreads cells around everywhere in the abdominal cavity, right? And what happened was in 2014, the myomectomy was performed, the specimen was taken out by electrosurgical morcellation, and suddenly it was found that it is a leiomyosarcoma. So basically a leiomyosarcoma was morcellated in the abdomen, and from stage 1, the woman went on to stage 4 with multiple metastases in the abdomen, of which she died, right? So the trust was sued, the hospital was sued, I think, and then the ruling came that it is not a very correct way of morcellating or crushing the specimen inside the abdomen to retrieve. And therefore, from 2014, most of the hospitals in Europe has started to avoid electrosurgical morcellation, right? So there was a period which extends up to now where electrosurgical morcellation is not performed. So as an alternative, 2 things have come up. One is we put a small incision, which I normally practice, just over the symphysis pubis, a 2 centimeter incision. A special port is put in, right? And then the fibroid is pulled up to the port, and then it is hand morcellated. That is with the scalpel, you cut it and remove. So therefore, spillage is minimal at that point. It is good if we have bags for that. However, the largest bag which we might have may not accommodate the size of the fibroids which you have. But hand morcellation through a port placed in the abdomen, 2 to 3 centimeter port placed in the abdomen, is a very good option to avoid spillage. Next thing is, there are in-bag morcellation techniques where a bag is put inside the abdomen after the fibroid has been removed and the uterus sutured. The fibroid is put inside the bag, then the bag is blown up like the abdominal cavity, and then the morcellator electrosurgery is put inside the bag, and the telescope also is put inside the bag, and then the morcellation takes place inside the bag. It's in-bag morcellation, which is showing extremely good results, right? In Sri Lanka, we don't have the bags, but it is being produced. It will probably, after this pandemic is over, we should be able to get there. Then we can perform in-bag morcellation with electrosurgical morcellation. So it is not the death of the electrosurgical morcellator and the morcellators. In the future, if we have good results which are coming up, then of course in-bag morcellation will become a possibility. Till then, in-bag hand morcellation with a hand port is an extremely good option. The cut is so small, so and therefore even it's not visible, and it's a very, very good option. So this is for specimen retrieval. The other option is, if we perform a hysterectomy and the fibroid is very large, we can do cold knife morcellation. We can cut the fibroid cleanly with a surgical knife, with a special knife, and then it will be cut into a volume where it can be drawn out through the vagina with the uterus. So that is also an option, which is called cold knife morcellation inside the abdomen, and the specimen can be delivered to the vagina if a hysterectomy has been performed alongside for the removal of the fibroid and the uterus at the same time. The vagina can accommodate diameters, or we can draw out diameters up to 10 centimeters. Remember, the baby's head is 10 centimeters. It can come out through the vagina. And therefore, when we pull a specimen out of the vagina, even 8 to 9 to 10 centimeters in diameter can come out through the vagina. So those are the options available for specimen retrieval. And these are the options available for surgical treatment of fibroids. Laparoscopically, any large fibroid can be removed laparoscopically, even 34, 36 weeks, right up to the abdomen, right up to the diaphragm, even can be removed laparoscopically, which is technically feasible. So when the abdomen is blown up with gas, carbon dioxide, we get more room, and therefore we can go around the specimens and perform a hysterectomy or a myomectomy. So laparoscopically it is feasible, but it needs expertise, and it needs good specialized care for that to happen. So those are the options available for surgical management of uterine fibroids. What are the other options which you have to talk about as undergraduates? Number one is uterine artery embolization, where radiologically the uterine artery is embolized. So therefore it embolizes the blood supply, the main blood supply to the fibroid that is there, right? And then the fibroid will shrink and it will cause degeneration of the fibroids. The main disadvantages, we are not entirely sure how it affects fertility, right? I have seen some disastrous results with women who have undergone this and who have fertility problem. So we are not yet very sure how it affects. So usually at the moment, if a woman requires fertility, they do not undergo uterine artery embolization. And basically, a catheter is put under radiological guidance, and the uterine artery that is feeding the fibroid is embolized with small plastic balls, and the fibroids are drained. So up to 50% to 60% reduction has been achieved in large fibroids. But the disadvantages are sepsis might occur. The woman can have abdominal pain, and she can have a lot of vaginal discharge from a degenerating fibroid, which may discharge into the uterine cavity. So those are the, but that is one option. Next thing that is coming up is ultrasound, focused ultrasound under magnetic resonance imaging. Basically, using MRI, you focus an ultrasound beam into the middle of the fibroid. This is high technology, and that heats up the fibroid, and that causes death of the cells, right? Fibroid cells, and causes them. So up to 50-60% reduction in the fibroids have been found, but it requires MRI. It requires a lot of expertise and a lot of, so it is a modality that is coming up, but maybe, but extremely probably expensive, and long-term consequences on fertility is not known. So we do not know how it's going to come up, but it is seems to be a very good non-invasive, minimally invasive method of treating fibroids, which may be there in the future. Then there is cryolysis, which is putting something inside into the fibroid and causing, making it very cold so that the cells will degenerate, but a lot of problems with that technique. Then there is myolysis, where you put, or laser myolysis, where you put a laser what is this? What is that called? A laser. You can understand what I'm saying, right? Because it's like a stick, right? You put it inside the fibroid. And you, sorry.
Is it laser probe, sir?
Yeah, laser fiber. Yeah, fiber, right? Not a probe exactly, but it's a thin fiber which is put inside via a special cannula into the fibroid. Then you give laser treatment to the fibroid that causes the fibroid to shrink and degenerate, right? So those are all experimental. They are not caught up because it takes a lot of effort to perform that, to place the fibers laparoscopically. So it's a very, very complicated process. But just remember, these are possible, right? And be treatment options that are available in the world, but it is not done in a very sort of wide manner. So those are the available options for fibroid treatment other than myomectomy or hysterectomy for fibroids, right? So that is one. So follow up, of course, remember, if we do a myomectomy, essentially with opening into the cavity, then probably we need to be very, very careful. I told you about vaginal birth after cesarean, which we had a discussion. So we might need to perform a, remember, a cesarean section for women who have had a myomectomy, which opened into the cavity, right? So that is basically the management which I wanted to discuss with you all, right? And usually if we do a myomectomy for infertility, we advise them not to get pregnant for at least 3 months, right? Until the total scar or is very well healed, right? So that is what I wanted to teach you all, right? You all want to have a look at a myomectomy, a video? Is it a yes or a no? Oh, 11:41. I will just show you, right? Okay. Let me find one for you. I can just lift it off my workshop. All right, because I had myomectomy. Okay. Fibroids. Right, give me a second because I didn't have. I didn't have time to choose, but I'm just trying to find a hysteroscopic resection for you. Right, so I'll just quickly show you a myomectomy. Right. Can you see my screen, children? Yeah.
Yes. Yes.
Yes, sir.
Right. Okay. So this, can you see it's a fibroid? It's a laparoscopic myomectomy, right? Can you see how large it is, right? So I'm going to skip that quickly, and these are the ports coming in. The size actually doesn't matter for our myomectomies. Any amount we can do them laparoscopically, right? Any size. Ovaries, you can see how large it is. I'm going to just, right? And I forgot, tranexamic acid can be used during laparoscopic myomectomy to reduce bleeding, right? 1 gram. And vasopressin can be injected into the myometrium, not into the fibroid, to reduce bleeding. Okay. You can see that is the uterus that is down there. Can you see? And it's the fibroid that is jutting out. So you can see the ovaries have been crushed or shaped into stone like lasanara Ganga and fibroid has. You can see both ovaries look like discs. They have been crushed against the neck, right? Yeah, right. So that is the rectus sigmoid. She had a bit of constipation. It is a very large one, right? And I think she had infertility because of spoiler. You can see that is the bladder. That is the uterus, and that is the bladder which I touched, and this is the uterus. But the fibroid is quite large, right? So I'm going to go quickly, right? I just explaining to my assistant, I think, as to where we will cut and how we will cut. But I think initially we will need to inject vasopressin in. So I will show you that as well. Vasopressin will reduce the blood loss, right, which is important. Yeah, that is the vasopressin is going in, and you can see the uterus becoming whitish. Okay, as the vasopressin goes in, it's 20 international units in 100 or 200 ml of normal saline, which is injected not into the fibroid, children, but into the myometrium. You all understand, right? And that is, you can see it's getting whitish, right? So one of my patients are actually watching this. They just texted me. Right. She also had a similar myomectomy, about to deliver next week. Right. So you see it's becoming whitish, right? So I'm going to, yeah, can you see how whitish it is becoming? It's, so now once that is done, now we have to cut the fibroid. So this is the minor. So what is very important is this is monopolar cutting, children. It's a monopolar hook. So what is very important here is to find the, remember, fibroid myometrial plane, or a plane between the correct plane between this. So it can be enucleated out, right? Otherwise we'll be removing the fibroid as well, right? So we need to have a sufficiently large cut on it. So monopolar will cut very nicely, or even a blended one, right? You can see that the fibroid is slowly coming into view, right? Right. So I'm going to just, that is the cut. The next thing is a myoma screw will be inserted into the fibroid, right? To give traction, so that I'll be able to quietly be able to take off the myometrium, to dissect the myometrium of the inner. So what is, whitish, you have to find the correct plane. This sometimes, although it looks like the fibroid, is actually the myometrium which has been crushed and it becomes not reddish but whitish, right? Yeah, can you see the plane coming into view? So it just peels off if you get the correct plane. That you can see that blood vessels growing around the fibroid. You can see that, that is where because there are no blood vessels going into the fibroid. It is always on the surface. I told you, remember? Because all this started off from one cell, imagine, right? There must be billions of cells there, right? So that is bipolar. So in normally these surgeries, we achieve hemostasis along the way. We don't normally just take it out and then try to sort out the vessels. We achieve hemostasis along the way, right? So this probably will need another smaller cut because it's not popping out. So another cut. Right, so I'm going to advance this a bit. Right, advance till it's coming out. So this takes time. Coming out, still coming out. Can you see that? Right, I'm going to go fast. Still coming out. So we have to be very careful where the fibroid starts and the cavity starts. Otherwise, we will take off the cavity. Right. So therefore, you see that is the uterus now, but that is the flap of the uterus which was encircling or covering the fibroid. So that has to be slowly dissected off. So I will go quickly still. Because it is the vasopressin that was there that caused minimal blood loss. Otherwise, she'll be having torrential bleeding by now, right? So I'm going to go quickly. And now you can see that the fibroid has been removed from the uterus. And you can see that is just the cavity that is down there. So you can see there's one the small fibroid. So this is basically a myomectomy. So I'm going to just go quickly. There's another one. So that is the second fibroid. You can see that is coming out. Can you see that? So that is the second one. So it was just lying underneath the first one. So now in this instance, remember, we have to be very careful because if we go with the wrong surface, we will take out the cavity with us. And that will be the end of her fertility. Because I can't remember this case exactly, whose or what, but I think fertility must have been an issue. So in this case, even when the large one has been taken out, the second one will be sitting on the cavity. So therefore, it needs very, very careful enucleation. Can you see? So it has to be, when I'm going down, it has to be very, very careful, and we have to cut right alongside the fibroid itself and leave the myometrium intact to make sure that I'm not taking out the cavity. It doesn't really matter even if you open into the cavity. You can do the suturing, so that's not a problem as long as the cavity is intact, right? So opening into the cavity is not a problem at all during myomectomy. If it, open it, you just suture it, right? So, but you need to do a proper job about suturing it, but that of course is not a problem. So can you see how carefully it must be done to make sure that you are just removing the fibroid and not the cavity, right? And sometimes the myometrium also looks whitish. So that's all done. Both have been removed, and that is the cavity. Can you see? That is the cavity. So the cavity has been opened, and that is the endometrium. So you can see how close the association was between the cavity, and I opened it into it purposefully, although because to make sure that there's no fibroid there, I'm cutting it. So I just wanted to make sure that is the cavity that is, the endometrium or the cavity that is jutting out. So I'm going to just make sure that it is not another fibroid to make. So I made a hole in it, and then I see the endometrium, and I know that it is the 100% the cavity. Can you see how it juts out, right? So here you will just need a few sutures to make sure that it is the cavity, and then you can see that the endometrium is just jutting out. So we put a few sutures there, and that so that was opened purposefully, which can be done. That is the cavity. Got it? Can you see how the endometrial myometrial junction is, and the fibroid was sitting right on top of that. So if you are not careful, we'll just remove the cavity itself. So this is a very good demonstrative video as to how careful we need to be in this. So the next part, children, is suturing. There are a few fibroid outside, so that's removing those, right? So that now we will stop. Okay. So that is a myometry. Do you all want to look at how it was removed? Wait, let me just check. Right, can you see this? Yeah, okay. So I will just show you how. Now this is just another fibroid that was coming out, remember? And that is slowly it's going to starting to bleed because the effect of vasopressin is wearing off, right? So now the cavity, you can see the open cavity, and now we are going to, I'm going to do the suturing, right? So there are the cavities getting sutured, can you see? So it is, so one stitch is enough, more than, even if it is left unsutured, that's all right, because we are closing the myometrium over it. So that's a problem. That now that has been stitched, right? The stitch is done. So it's laparoscopic suturing. Yeah, so that is the cavity has been covered, you can see. And now the next step is the suturing of the myometer. So it's closed layer by layer, which is very important. So first layer one, then muscle. These are stitches which barbed stitches, where you can see the barbs on the inner, because when you draw it, it doesn't go back because there are barbs like an arrow, right, with feathers down there, you can see. So you can see, you know, that barbed sutures. So it's, you pull it one way, it doesn't go the other way because there are barbs in it, right? So that is what we commonly use, but anything can be used. But so that is suturing. You can see that it's been closed in layers. Layers still getting closed, still getting closed. So slowly it is getting closed. Right, so can you see now? There is one. There are a few more things to suture there. Another side there, but you can see the main thing suture. So this is actually a laparoscopic myomectomy. I just wanted you to understand what it means. If there's anything right, I will show you quickly something about specimen retrieval, and then we will end the session if there are no questions. Right, this is a right. So this is a port which I told you about. See, can you see that port has been put into the abdomen? Can you see that? And the fibroid is fed into the port, and then morcellation or hand morcellation is done from above. So that is one of the ways which the fibroid is released, right? So that's basically what I wanted to show you. There are many more videos, but we don't have time for all that. So that is all, right? So a total of 100 have not slept. I'm impressed with the interest generated by our undergraduate students in the quest for knowledge, right? And okay, so let us go into the gallery where I can see some of the sleepy faces, right? And I'll just answer the questions, children, and we'll wrap this up. Are all medical therapies only for menorrhagia caused by fibroids? Yeah, there are no. Mifepristone is an experimental thing that causes shrinkage of fibroids because it is an anti-progesterone, mifepristone, right? So it might be an experimental thing. Then ulipristal acetate causes shrinkage, and then but however it is not licensed now. Progesterone receptor modulators like raloxifene and may cause shrinkage of fibers, but it is still not licensed and it is not very effective. So most of the therapies that we are using, which I spoke to you all about, is for the reduction in bleeding for patients who are having menorrhagia due to fibroids, right? Somebody has written probe. I don't know what that means, so I'm going to skip that. Then somebody has written, yes, sir, but probably it's the answer to one of my questions. Is there anything we need to know related to fibroids with patient education related to any emergencies, red flag signs? Is there anything we need to know related to fibroids with patient education related to any emergencies, red flag signs? Right. Now, of course, if you go to the Royal College of Obstetricians and Gynecologists, there are patient information leaflets where you need to just check on those, and there you will see the information leaflets pertaining to proposed myomectomies or hysterectomies due to fibroids, where it answers almost all the questions that a patient would ask. Are there any emergencies due to fibroids? The emergencies are pain due to degeneration, but the pain may not be acute. But the emergency is if a pedunculated fibroid twists, then there is acute pain, and therefore it can be an emergency, right? Of course, the other thing is if there is a submucosal or intracavity or which causes severe bleeding, which causes the hemoglobin to come down to 3, 4, sometimes 3, then of course it is an emergency where you need to treat, but right, you will need to give blood, you need to do certain things, so that also can be thought of as an emergency. Red flag signs, basically red flag signs means you need to be worried about something, you know? So yes, if the demarcation is not very good and we are really not sure whether it is a fibroid, of course you need to go to an MRI, and of course a general ultrasound scan and instill see whether there are any metastases there where we are missing something, lungs. So leiomyosarcoma may not only be present in the uterus itself, there may be mets everywhere which you will miss if you do not do a general investigation of the abdomen as well, right? So therefore most of these problems can be sorted by doing an ultrasound scan of the abdomen and a ultrasound scan KUP before you do any kind of intervention, gynecological intervention. That has to be ruled. So I always, for every patient that undergoes minimal access surgery, I always make sure that they get an ultrasound scan of the abdomen and a KUB as a minimum requirement for us to go into surgery in the pelvis, right? So that is a good way to practice that will cause you a lot of less grief in the end. Doesn't it lead to placental malpositioning, previa and and all cutting into the cavity and resulting. No, the cutting into the cavity is not a problem, because one thing is, when you cut into the cavity, you basically, if you do a proper suturing, then there is no problem at all. So therefore, routinely in open surgeries as well as laparoscopic surgeries, we can cut into the cavity and see. Especially if you are not really, if you are not sure whether it is another fibroid or whether it is that, you can put a small nick and see, right? So cutting into the body, no, it doesn't cause those problems. Can we say COCP is a treatment for fibroids? Because it's not a definitive treatment. It's not a treatment for fibroids. COCP is not going to treat your fibroids. It's going to treat the menorrhagia caused by fibroids, right? So you cannot in a blanket way say this is a treatment for this. You need to specify why you are using oral contraceptive pills, and you use oral contraceptive pills to reduce the bleeding, which may be caused by fibroids. Okay. However, fibroids and adenomyosis can coexist, where even if you remove the fibroids, the menorrhagia will continue, because the menorrhagia may probably have, or can be, or might be because of adenomyosis and not because of the innocent fibroid sitting quietly somewhere in the corner, right? So you have to be very, very careful as to what you do when you have it, because if you, in conjunction, if you diagnose adenomyosis along with the fibroid, and you go and say, okay, it's a fibroid, let's take it out, your menorrhagia will be sorted. You take it out and the patient will come back, doctor, I have the same amount of bleeding before as well and after as well. So what is the reason? Because you have not diagnosed the adenomyosis. You have just gone after that very innocent looking fibroid and you are taking it off, and still the menorrhagia is going to continue because it was originally because of adenomyosis. So therefore, a hysterectomy may have been a better option for this patient if she has not completed the family. Okay. Is pregnancy normal delivery possible with fibroid? Yes. There are so many patients who get pregnant, they come to you, and then you find the fibroid in them. So therefore, there are patients with fibroids complicating pregnancy. Of course, it can give problems. Miscarriage is higher, pain problems are higher, malpositioning is higher, placenta previa may be more if there are fibroids, then because the placenta parks itself in the lower segment. In a normal delivery also, there is a dystocic labor because the womb does not contract uniformly and nicely. If the fibroid is lower than the presenting part, it cannot come out sometimes, or you might have dystocic labor, or malpresentation is commoner. Yes, so pregnancy normal delivery is possible, definitely yes, but it has to be thought of case by case and be checked during labor as to whether it is functioning well. Right. So I think we have completed all the questions, and then we will wrap up this session. Yeah. Right. Okay. So then, good night. Tomorrow, I think I am doing the, what is this? I am teaching the postgraduates, because I have, I do a session for the postgraduate that is purely surgery. So if any of you are interested, please feel to join. It is, the group is called group is called O&G PG, postgraduates, right? So therefore, if you all are very much interested in surgery, you all can join and watch. Okay, right. Okay, somebody has just typed in a last minute message. Okay, let's see. Can you please do normal labor as the next session? Okay, Yeah, I actually wanted to do that. Today's topic was proposed by a gentleman who I know, right, who has had many AOs now. But yes, normal labor, yes. I will do normal labor next session. Normal labor has to comprise of several segments. We'll do CTG as one total segment, one session, right? Which is, it takes long time, 1.5 hours. Normal labor, I will lay out all the principles of oxytocin management, everything. We will do it next time. Yeah, sure. Partogram, all that thing we'll cover next time. Okay. Okay then. Good night.
Thank you,
Good
sir.
night,
Good
sir.
night.
Thank you, sir.
Bye.